Hello and welcome to our podcast, The Doula and The Doc, hosted by Vanessa Salerno, a birth and postpartum doula.
As well as Dr. Joseph Scroy, an obstetrician, gynecologist and fertility specialist.
Together we'll be discussing a range of topics from preconception, pregnancy, birth and also the postpartum period.
Together we combine holistic insights and medical expertise. We dive into women's and men's health with honest information and sometimes the unexpected conversations.
This podcast is where evidence meets experience, so let's start the conversation. Please note the information provided in this podcast is for educational and entertainment purposes only and is not intended as a substitute for professional medical advice, diagnosis or treatment. Always seek the advice of a qualified healthcare professional regarding your own pregnancy, birth and health-related conditions.
This season of The Doula and The Doc is brought to you by Libra.
Welcome to the Libra Odd Spot.
Yes, if anyone knows when you are in the bathroom and you are taking out your pad, we have odd spots and we love to sit and read while we're in the bathroom.
So stop scrolling and start reading.
Fingernails grow faster than toenails.
Did you know bees fly at an average of 15 miles per hour?
This episode we're talking about period talk, okay? So beyond the basics and all the questions that people don't ask, not sure about. And as women, as much as we are meant to know about our cycle, let's face it, we don't until we have to.
It's interesting, isn't it? We go, the most common thing about ourselves is ourselves. And yet, even at school or throughout our lives, we never get taught about the intricacies of our body and the mechanics of our body.
Oh, we don't.
That's one of the things that drove me into medicine, is to understand how this thing works, you know, how it all works together and what makes us us.
Yeah.
But yeah, cycles, women's cycles, you know, people coming for fertility, understanding periods, understanding the fact that, you know, periods aren't meant to be painful.
Are you surprised as a doctor, though, when people come and see you, how little knowledge they actually have?
Absolutely. You know, even the timing of when to have sex in order to conceive. Also, there's a lot of biases when it comes to a woman's cycle, how heavy it should be, how painful it should be, or should it be painful? And of course, unfortunately, modern medicine has sort of dismissed women for a long period of time about their periods because it hasn't been something that's been openly talked about.
Because, you know, as we were growing up and you still hear it's just a period.
Well, not only it's just a period, you know, young girls were too scared to speak to their mum about it. So there wasn't that sense of handing over knowledge and wisdom. Maybe more so I would say more so in an Anglo-Celtic sort of society. I think there's some societies that do it quite well. I understand the Japanese do it quite well. Probably, you know.
How do they do it a little bit different to it?
Oh, they just celebrate stuff a lot more, right? They celebrate a woman's coming.
When my niece got her period, my sister made such a big deal.
Bring out the champagne.
Yeah.
Oh, no, okay, not for 12-year-old.
But she brought out the cake and she was, and her brother was like, "What are we doing?" And she's like, "She got it." And she's like, "Oh, we're celebrating this." You know,
I think it's important, and I think that, you know, again, social media, some good, some bad, but maybe the explosion of information about women's health, about periods, is really important because it is driving discussions, and ultimately, the ultimate goal is obviously better health outcomes for everybody.
Yeah. So, what do you think? Like when we're talking about cycles, what do you not think that people understand? Like, people don't understand their stages, right?
Well, they don't understand stages. They don't understand the complexity of what happens with the ovary and the uterus. They're two separate organs, right? Or two separate things, but interrelated. Yeah. And also then there's the brain. The brain, the ovaries and the uterus, they all work together to give us what women know as their periods. And so let's try to unbundle what that all is.
So tell me.
So what I want to sort of, I like to sort of use flowers and grass and fertilizer as sort of the analogies.
One thing they'll learn on this podcast, you have a lot of analogies.
I have a lot of analogies.
Yeah.
Absolutely.
It makes sense.
Absolutely.
Okay.
So the uterus is obviously the womb. That's where one day, hopefully, if you want to, of course, we'll have a baby. The ovaries are where all the eggs are contained, and the ovaries then release the eggs. They come down the fallopian tube where fertilization occurs of the egg. And then lastly, of course, you've got the brain that secretes hormones that regulates everything. So I want you to imagine that firstly the ovaries containing all these eggs. So if ever you've seen an ultrasound of your ovaries have got lots of little black circles in them. They're like little eggshells.
Okay.
So some women, we talk about polycystic ovaries. It's a bit of a misnomer, actually. Polycystic ovaries is just polyfollicular ovaries.
Okay.
It means that the ovaries has got lots of follicles and lots of eggs. It's actually a good thing, not necessarily a bad thing.
Okay.
But I want you to imagine the ovaries with all their little follicles are like a flower box with lots of little sunflower seedlings in them.
Yep.
Okay. So every single month, the brain will secrete a hormone, comes all the way from the brain down to the ovaries, will secrete a hormone called follicle stimulating hormone, otherwise known as FSH.
Yes.
And that acts like fertilizer for the sunflower seedlings. So if you've got 20 sunflower seedlings every month,
yep,
then the brain will secrete this hormone called follicle stimulating hormone, which will allow one of the sunflower seedlings to grow into a big, beautiful sunflower.
Yep.
And that will ultimately block out all the other little sunflowers from growing. And every month, every 28 days, a woman will then ovulate, which is a bit like picking that sunflower and putting it in a vase.
yes,
And so much in the same manner, the brain secretes a hormone. It comes down to the ovaries. It stimulates one of those follicles to grow larger and larger and larger to a point in time where ovulation occurs. The woman then releases the egg. All the other little follicles, they get suppressed because in humans, we don't want to have more than one child, generally speaking, because it's difficult on the woman to have more than one baby, but it's also difficult for us as humans, if we're out in the wild, to care for more than one baby as well. So out in the wild, I mean, when we were sort of running around the jungles. And so then one egg's released and that egg has the opportunity then to fertilize.
Yep.
Where that eggshell opens up, the eggshell within the ovary, it then collapses on itself.
okay,
And that collapsing on itself, you can imagine this eggshell within the ovary opens up, cracks open, and then the eggshell collapses on itself. And during that latter part of the cycle, the woman will secrete from that cracked open shell progesterone, or pro meaning for something, gesto meaning gestation. That's where the word progesterone comes from. And that cracked open shell has got 14 days of actively producing progesterone until it cycles out and stops producing progesterone. So the first part of the cycle is this follicle developing, the sunflower growing. That's producing lots of estrogen, pumping estrogen out into the woman's body. And the second part of the cycle, whilst there's still a little bit of estrogen being produced, the predominant hormone now is progesterone, or that pro-pregnancy, progestone, gestation hormone that then supports what should be what the body's hoping is a pregnancy. Not necessarily, you don't have to get pregnant, but pregnancy. And then at 14 days, that eggshell collapses on itself and it stops producing progesterone unless you become pregnant. And if you become pregnant, if that egg has had an opportunity to fertilize and produce HCG, which is a pregnancy hormone, that will continue to force the eggshell that's collapsed on itself to produce more and more progesterone for a period of 10 weeks at least to support the pregnancy until the placenta kicks in.
okay,
Now, on the flip side, we've also got this uterus. And this uterus is expecting at some point to receive a pregnancy, a baby. So the first part of the cycle is where the follicle's producing a huge amount of estrogen. Now, what I want you to imagine is that the lining of the womb is like the surface of the MCG. Okay, it's got grass on it.
yeah,
And the estrogen that is being produced by the follicles, or those sunflower seedlings that are growing in the sunflower box, that causes a thickness to grow within the lining of the womb, a bit like the surface of the MCG growing.
grass, yep,
If a woman becomes pregnant, then you can imagine it's like a beach volleyball that's going around the MCG. Someone's doing Mexican wave with the beach volleyball, and the beach volleyball lands into the grass and gets nestled in there. And then it'll produce HCG, that pregnancy hormone, and continue the cycle of producing more progesterone. But let's say you don't become pregnant. Then what ends up happening is that grass continues to grow during that first part of the cycle. The progesterone, which is that pro-pregnancy hormone, stabilizes the grass, thinking that maybe a pregnancy will come its way. But if you're not pregnant, then that eggshell stops producing progesterone, and it's like that grass that's been watered and fertilized with estrogen and progesterone now no longer gets any water or alternatively any progesterone.
yeah,
and the grass starts withering away. So along comes the groundskeeper and comes and cuts all the grass, and that's your period.
Yeah.
So there's this interplay between what's happening with the brain, what's happening with the ovaries producing estrogen and progesterone, and what's happening with the lining of the womb that thickens initially, the lining thickening, and then subsequently a withdrawal of all the hormones that causes your period. So your period marks the end of a cycle, and also the start of a cycle. So we always say that the first day of your period is the first day of your next cycle. And most women will have a 28-day cycle. The growth of that particular follicle, generally speaking, in most women, will be around about 14 days plus or minus a couple of days, with ovulation occurring around that 14-day mark. And then, as I said before, that pre-programmed eggshell lasts about 14 days before it collapses on itself and can't produce progesterone. And then at the 28-day mark is when you have your period. But of course, women can have longer cycles and they can have shorter cycles. But the time that's pretty much pre-programmed is that period of time from ovulation until when you have a period. So that is predetermined by that eggshell that produces progesterone. So that collapsing of the eggshell that produces progesterone is generally speaking 14 days plus or minus a couple of days. So if you have a 35-day cycle, then the time from ovulation to when you have a period is always going to be 14 days. So that means ovulation's occurring day 21. So not day 14 as in a woman who's having a 28-day cycle. So if you're having a 40-day cycle, you count back 14 days, right? And that's going to be 26. If you're having a 24-day cycle, well then 14 days before that's when you're ovulating. That progesterone, that pro-pregnancy hormone's only around for 14 days. So that means ovulation occurs day 10. So this is how we work out when ovulation occurs, and more importantly, if you're trying to become pregnant, when you should be actively trying to conceive. And of course, if you're not trying to get pregnant and you're using sort of the Billings method or a way of avoiding sex during ovulation, then that would be the time that you would also avoid it. So part of the whole understanding of that complexity is understanding the relationship between the brain, the ovaries, and the uterus. And the timing.
Well, we never get told that.
We never get told that, absolutely. And so part of, you know, whenever
I can't even remember how I was taught at school about the whole period. Like, it was just...
I don't think anyone teaches anyone. And so a lot of what I do when I see couples, particularly with respect to fertility or preconception advice, is actually draw sunflowers sitting in a sunflower box. I draw the surface of the MCG and the grass growing, and I show them the brain sending fertilizer hormone down to the ovaries so that you get that visualization of what's actually occurring.
So when things like endometriosis is around, what does that look like then within?
So endometriosis, one of the great things I think both parties in terms of federally, whether it be Labor or Liberal, is this bipartisan approach to understand that women's health has largely been underfunded, and more importantly that we as a profession, as a medical profession, have sort of ignored women's concerns with respect to their periods and pain for a long period of time.
We've seen it currently in the media about the truth of endometriosis.
Absolutely, yeah. We shouldn't mention his name because he doesn't need any more publicity, that bloke. But anyway, but we know that blokes, generally speaking, don't get it. There are some guys. Actually, I'm actually going to do a little shout out to my son. My son is very in tune with things in terms of, and maybe in part because he understands stuff. But I think as a 14-year-old boy, he has a really good understanding of women's health issues, and it might be largely because of me. But he does understand these sort of things, these complexities. I don't wonder whether it's actually because he has a dad that's an obstetrician gynecologist, but he's pretty in tune with all that sort of stuff. So I think there is something to be said that the education system is changing a little bit.
Which is good.
Absolutely. But in terms of endometriosis and pain, we know that the lining of the womb, as I said before, has this grass that's growing. That's called the endometrium.
Yes.
Now, those cells get thick during the menstrual cycle, and then in the absence of you becoming pregnant, they will shed away, as I said before, and they become a period. But where you've got cells that are very similar to the lining of the womb that are located on the outside of the womb, and you've got to imagine the uterus is sitting in your pelvis as a woman, it's almost like your body or your pelvis is a bit like a bucket, and you've got your uterus that's sitting inside the bucket, and in your vagina and the bowels and everything sort of sitting there, your ovaries and all that sort of stuff. But on the side walls of the bucket and on supporting ligaments that help support the uterus so that it doesn't come out of the vagina. So you've got ligaments that
Even
support
though
it.
sometimes it feels like it's going to fall out.
Yep.
I'm not going to lie. Yes.
TMI on this program. Anyway.
It's for the listeners, Joe.
For the listeners. All right. But where you've got cells that are located on the outside of the uterus and on the supporting structures of the uterus, it's called endometriosis.
Okay.
Now, of course, those cells will undergo the same hormonal influences as the lining of the womb does. So we get nice thickened endometrium, but endometriosis thickens up.
Yeah.
But there's nowhere for that to bleed. It doesn't come out through the vagina or through the cervix and the vagina. So as a result, that endometriosis then causes an inflammation within the pelvis. And along will come these inflammatory cells that try to mop up that endometriosis.
Yeah.
And as a result, it leads to pain, and largely pain, and also concerns with respect to fertility. So some women will have concerns with respect to not being able to conceive and or pain.
Yeah.
And so then as a gynecologist, one of the things that we then need to do is look at that pain symptom and try to work out, of course we need to do something about it, but what are the steps that we can do? And some of the things in terms of endometriosis can be very simple, like diet and exercise are particularly important. We know that exercise, if you exercise regularly, you are going to reduce the symptoms of endometriosis.
Okay.
There's also anti-inflammatory type diets that we can do in order to reduce the symptoms of endometriosis. And
alternative medicines, do you see? Yeah.
Absolutely. And then there's education, understanding the whole process of endometriosis and what that means for you in terms of fertility, in terms of pain. And then there's medical management, and that medical management is 3-tiered. And the first one, as you said before, is alternative medicine, which is predominantly traditional Chinese medicine. In actual fact, when I did some of my training in gynecology, I spent some time in Thailand at Siraj Hospital, which is a major Bangkok hospital. It's where the late king actually spent his last few years. It was a very world-renowned university hospital in Bangkok. And a lot of the Thai doctors have a Chinese background. I think their heritage may have been Chinese. So they use a lot of traditional Chinese medicine. And in fact, the endometriosis clinic that I went to in Bangkok had the traditional medical system and the traditional Chinese medical system. And when you had your diagnosis of endometriosis, you would see the same doctors who practice Western medicine as well as Eastern medicine. So you get treated from both perspectives in the one clinic.
Okay.
It was part of one of the reasons why as well. We've talked about this whole village that I've hopefully created in my rooms, which is all about building in supports for women and for couples during their fertility journey, and why we've got a naturopath and traditional Chinese medicine within the rooms to support women during their diagnosis for fertility and or endometriosis. And so we know that acupuncture actually reduces the symptoms of endometriosis. And then you've also got medical management that includes non-hormonal treatments, and that's non-steroidal anti-inflammatories, things like Ponstan or Nurofen, and then medical management, which ultimately includes hormonal treatments. So the non-hormonal and then hormonal treatments, the contraceptive pill, the Mirena IUD, these are the sort of things that we also do. And lastly, surgery. And one of the good things about being a fertility specialist, an obstetrician, and a laparoscopic surgeon as I am is that I offer all those areas. I think some women, and I unfortunately have seen some women who've gone specifically to see an endometriosis specialist whose only trick really is surgery. Like that's what they do. Their bread and butter is doing surgery. And so a lot of women will be offered surgery as the first port of call. And I'm not saying that's necessarily not the right thing to do, but I think it's important to explore the plethora of treatment options before surgery. And I say to my patients that there's only 2 reasons for doing surgery. Number one, conservative measures have failed. And so what I mean by that is traditional Chinese medicine's failed, diet, exercise has failed. In addition to that, hormonal or non-hormonal treatments have failed, and you're still getting pain that's impacting the quality of your life. And that's the key, How much pain have you got? How much impact is this having to the quality?
Debilitating.
Absolutely.
Just like, I've had friends that have been like on the floor of the shower And
Absolutely.
it's just they can't.
I mean, there's the cost to the person from a mental health and well-being perspective, a cost to them in terms of days off work, a cost to our community in terms of people not being able to go to work. So there's a large cost. And then, the interpersonal relationships that get effects with people, your loved ones that are around you that are seeing you in pain the whole time. So when those conservative measures fail, then I think we need to consider surgery.
Do you think it's obviously more discussed now than it was like 10, 15 years ago, because everyone was like, it's just a period. That's just what you do. And it was never just discussed.
Yep, absolutely.
Or didn't know how to explore it, do you think?
Absolutely. Just back before.
Yeah.
So in terms of the surgery then, so number one is related to the fact that, medical conservative measures have failed. But the other thing is if we're trying to actively conceive, because of course when we're trying to actively conceive, we're not going to be able to use a lot of the medical management.
Yes.
And so we may end up doing surgery, because we know that if we remove endometriosis, we're actually going to really increase the chances of pregnancy dramatically if you're trying to conceive naturally. If we're doing IVF, less of a reason necessarily to do endometriosis surgery. But if we're having concerns with trying to conceive naturally, one of the things I'll always offer is a laparoscopy to look and treat for endometriosis, and then also confirm the tubes are open. And that then leads to improvements in patients or in couples becoming pregnant naturally. But back to your point about, have we ignored it? I think for too long we have ignored it, and in part because there's been just an acceptance that women should have heavy and painful periods. That's the other thing. You can have heavy periods with endometriosis, and that ultimately it's just been ignored on that basis. But with increases, and you've got to imagine laparoscopic surgery's only been around for 20 odd years. 20, 30, maybe 30 years. And so prior to that, in order to treat endometriosis, women had to actually have a major cut. And that in itself had, like doing a Caesar.
And things
it had complications and it was
healing,
major surgery. So there wasn't that minimal invasive or less, when we do keyhole surgery, it's a day procedure. We're looking at endometriosis. And I've got to say, look, obviously doing what I do, one of the great things is being able to see people have really, debilitating conditions. And I think this is true of anyone who's in health, being able to help them through and navigate through a difficult time in terms of their health and then resolve that for them. And there's nothing better than being able to assist a woman who's having painful, heavy periods, bloating, pain with sexual intercourse, a whole range of symptoms that come with endometriosis, and then to be able to see them on the flip side of that and go, wow, I didn't know my periods didn't have to be painful.
Yeah, we don't. And I think that's going back to the education that we had as we grew up, because it's just a period, and it's normal to feel all these things. And for people not to understand, maybe I need to get checked. Absolutely. Until there's a reason, like you want to start a family and all those sorts of things. And then they go, well, this makes sense. I've put up with this all my life, and not knowing that there was a reason why this was happening to me.
Yeah, absolutely. I mean, I think that's the key. And I think if one thing, if you listen to this episode and you are having painful periods, then initially reach out to your GP.
Yeah.
There's wonderful resources, Endometriosis Australia, but go and see someone who can give you the plethora of experience in terms of managing your endometriosis, and realise that surgery is not always the right thing. Medicine's not always the right thing. There is an umbrella of things that we can do in order to assist.
Yeah, and I think too, we're a generation just to pick up and Google and find that reason. Do you know where, back 20 years ago, that's not something that we would have ever really done.
Yeah, I think one of the things, actually, it's interesting you say that. I think Australians have a really good health literacy. We understand our bodies a lot. When we talk about not understanding your periods, but we actually have a pretty good understanding of our own health literacy. And I was interested that there's a young registrar who's come out from Ireland to Australia. And one of the things that she said, her name's Sarah Murphy. Sarah, if you're listening, shout out to you. But she's working in WA at the moment. And one of the things that she said is that Australian women have a huge amount of health literacy compared to women in Ireland, so she's not necessarily not needing to explain things to
Okay.
patients, but the patient's already coming to her understanding their condition before she's even seeing them. So that's actually quite good, and maybe a proliferation of ChatGPT, or Chat as it's called now, and also Google. Absolutely.
Yeah, and I remember back in the day when we used to have Dolly Doctor.
Yeah.
And there would be this, ask the doctor, and it was the first thing, I think everyone would get this magazine and they would just rip down the side to know, am I normal?
Absolutely.
Like, is this normal? Is this, and that's how we learned back in the 90s. That's
so now I'm the legal doctor.
Yeah, you are. Yeah. But that's how people we would know, is this normal? Do we have this discharge or this like is this normal? Because we were like, oh, maybe then, and that's how we would learn.
But also, women weren't, or young girls weren't, they were worried, or they were anxious, or they didn't speak to their parents about stuff. So you did get a lot of information from the sealed section.
Yeah, and I remember my mum always would talk about when she would get her periods back again in Italy, and she was like, we would never have these heat packs. And she was like, when my mum's in her late 70s, she's like, we would heat up a brick. And put a towel there. Like,
oh my God, heat up a brick.
Yeah, because they would never have that. Like she was, and all the things that they were, she's like, and the pads, obviously now, they're not like surfboards. People don't feel, insecure wearing an outfit because now they feel supported. And that back in the day, it was just like, oh my goodness.
Well, back then they would use pieces of cloth, wouldn't they?
Yeah, they would. Yeah. And that's what she would always say. And I was like, Mum, you must have had endo. Like, I was just like the way she talks about her period. And she was like, oh, yeah, probably, but we just would have never
And that's the other thing. Endometriosis does, run in generations as well.
Can you develop at any stage? Like, is it because that you've always had it, or can sometimes you develop after pregnancy? Or
look, I think the symptoms might come and go in terms of like of your menstrual cycle. Yeah, absolutely. During your menstrual life, rather.
Yeah.
Endometriosis, there's many theories as to why it occurs. Some people think that perhaps the lining of the womb comes back through the fallopian tubes and enters into the pelvis.
Yeah.
Some people think that the actual cells themselves change, because you got to remember that, as humans, we all come from, one embryo, so that you could actually have cells that could differentiate into endometriosis. So there's many different types of theories. Ultimately, the pathology is the same, and it's an insidious sort of disease. You can have a woman that's got a few spots of endometriosis in their pelvis and be in excruciating pain. And the reason for that is that the endometriosis actually, some forms of endometriosis actually encourage nerve endings to come towards the endometriosis. So those few spots can be, my God, really painful. Whereas another woman might have endometriosis everywhere, but actually not have any symptoms because she doesn't have any pain nerve fibers with the endo. So this is why.
And how would that ever be picked? You just
normally with an ultrasound.
Yeah.
And that's the other thing. One of the things about ultrasound scans, a lot of people say, oh, there's no endometriosis on my ultrasound scan. My periods are painful, but there's no endo on the ultrasound. Endometriosis can be picked up on an ultrasound scan if it's large deposits of endometriosis. It's not going to be picked up if it's very small deposits of endometriosis. The best way of thinking about it, imagine you're in a dark room, and you've got a painting that's in a frame on a wall.
Yeah.
If you turn off the lights and you run your hand, so you can't see anything in the room, but you run your hand across the wall, you'll easily be able to detect that there's a frame there, right? That's a large deposit of endometriosis. The ultrasound scan will easily pick up something that's jutting out of the wall, out of the pelvic sidewall.
Yeah.
But if you've got that same painting, the same picture of that painting, but now it's on a decal, so a sticker on the wall, and you run your hand now in that dark room along the wall, you may not feel it at all. You just walk your hand straight across the wall, or you wipe your hand straight across the wall. You're not going to know that it's there. And the only way you're going to know it's there is you turn on the lights and go, oh my God, actually there is something on the wall, but I just couldn't feel it. And that's the endometriosis that won't be picked up by the ultrasound scan. So the only way you can be absolutely 100% certain that there's endometriosis there is by actually doing a laparoscopy and checking and seeing and then removing that endometriosis.
Yeah. Yeah.
Libra comes in a range of pads from a liner with double 2-in-1, invisible, ultra thin, maternity, and extra protect.
My number one tip for your hospital bag is Libra maternity pads. Well, we've got some questions from some listeners that have...
Listeners' questions, I love them.
One question I do have is that people ask, if you start your period earlier, does that mean you'll hit menopause earlier?
It's a good question. Look, women are born, in fact, the most amount of eggs a woman will have will be when they're 6 months of age inside their mum's tummy. About 4 million eggs.
Yeah.
Once they're born, half of them are gone, 2 million.
By the time they're born?
By the time they're born, half of them are gone. Then by the time they hit puberty, 3/4 of them are gone. So now by the time you hit puberty, about 400,000 eggs are left. And over the course of your reproductive life as a woman, you will lose all those eggs to the time that you hit menopause when there's no more eggs. Yeah. And that's when we talked about the hormonal cycle, estrogen and progesterone fluctuating. There's not going to be any sunflower seedlings sitting in the sunflower box anymore producing estrogen. Now, earlier, it's not necessarily true then that just because you've started your periods earlier that you'll hit menopause any earlier. A lot of that's predetermined, maybe genetics. Mum went through menopause at 45, I'll go through menopause at 45 or 50.
Yeah.
So of those 400,000 eggs, as I said, many of them will get planted every month, like those sunflower seedlings were planted. Yeah. Only one of them will be released every month. So that's not necessarily true, but girls will experience their period, the start of periods, at very varying different times.
Yeah. Managing pain, obviously, and the irregular periods. So if you get one, you don't get one, what happens? Like, is it best to come and see someone like you? Yeah. How do we manage?
Well, I think, there's many women who have a condition called polycystic ovarian syndrome. And I talked about that before. It's a bit of a misnomer. It's actually polyfollicles ovaries. So lots of follicles on the ovaries. These women will have irregular menstrual cycles, and it's probably worth seeing a doctor if you've got irregular menstrual cycles, in part because it can also expose or potentially lead to other concerns with respect to your health. So diabetes, high blood pressure, a whole range of other conditions. So without being specific about polycystic ovarian syndrome, it is a window to your health, so to speak, in terms of understanding that there are the metabolic or other hormonal changes that are happening in your body that are contributing to the irregular cycles. And then the other thing, of course, is irregular bleeding in terms of bleeding in between your cycle. That's also important to investigate because the uterus, as I said before, is what causes the bleeding during a menstrual cycle. If there's any abnormality within the uterus, that can lead to concerns with respect to your periods as well. And that may be a window to what's going on within the uterus, whether there be things like fibroids or polyps within the uterus and the like.
Yeah. The other question is Mirena and the issues. What the benefits and the...
Yeah, so the Mirena IUD, look, it's been around for a fair while now. It's an intrauterine device that sits within the uterus and secretes progesterone, so that pro-pregnancy hormone that I spoke to you about before, that stabilises the lining of the womb. And in addition to that, it locally secretes progesterone within the pelvis, and it's particularly useful for women who've got heavy menstrual cycles and or painful cycles. So we use it a lot for suppression of endometriosis, particularly after we've completed surgery. It's got obvious benefits in terms of reducing symptomatology, so reducing heavy periods, reducing pain, but it can have, some women will have concerns with respect to it. One of the things I always say to people is don't be fearful of modern medicine. Don't be fearful of hormones that we're utilising.
Yeah.
Part of the things that, part of the good things about medicine is that if it's not working for you, we can always remove it. There's a lot of influences out there at the moment that are sort of dissing the contraceptive pill, for example, or dissing the Mirena IUD without really any evidence for doing that.
Yeah.
The evidence in terms of, let's say, the pill is that it obviously protects against pregnancy. For many women, that's important. It doesn't protect against sexually transmitted infections, and it doesn't protect against cervical cancer because they are sexually transmitted infections that occur because of the lack of use of condoms. So don't think that being on the pill and having sex with a multitude of people is going to prevent you from chlamydia, gonorrhea, and HPV and cervical cancer. It's not going to do that.
Yeah.
But we do know that it decreases the chance of ovarian cancer.
Yeah.
And we know that the background chance of a woman having ovarian cancer is about 1 in 70. Being on the contraceptive pill for a minimum of 5 years of your life actually reduces it by half to 1 in 140. I mean, if I gave you something that reduced your risk of something by half, and that's significant, you'd probably say yay to it, right?
Yeah.
It reduces the chance of endometrial cancer, and that's what the Mirena does as well. So this is cancer of the lining of the womb. And there's no increased chances in terms of breast cancer as well. So part of the concerns that many people have with the Mirena and or the contraceptive pill are born about, again, by people instilling fear in women. It's the paradigm of fear is so grand in our society at the moment.
You would see it all the time.
All the time. And I really hate when practitioners, whoever you are, whether you're an obstetrician, gynecologist, naturopath, traditional Chinese medicine, doula, midwife, whatever, if you are instilling fear into people about something in order to, I talk about, and this is going back to when I was working as a in my medical recruitment company. What do you do when you're trying to sell something? It's always fear of missing out.
Yeah.
That's one of the greatest selling tricks, right? Fear of missing out. We drive sales in business by making fear of missing out. This is your last chance. 99 cents, 50% off, only for 3 days. That's what drives people to sales. If your practitioner is driving you to them because they're making you fearful of something, they're not the person to go and see. Don't go and see them. Go to someone that's going to give you a breadth of things and say, hey, listen, this is what I do, but I see value in this and I see value in that. And that's, again, one of the reasons why I've got a naturopath in the rooms. I've got the doula in the rooms. I've got the psychologist in the rooms. I've got the physio in the rooms. And I've got myself, because we all come from things differently and we're all going to be complementary in assisting that person through their journey.
I think these days, we also go of the fear of, I don't want to consume, I don't want something in my body.
Correct, exactly.
So
absolutely.
That's where it's like, we'll do an alternative, but sometimes there isn't an alternative, right? So
there's not an alternative that necessarily is as good, right? And also the other thing to be mindful of is...
because we're so conscious of what we're putting in our bodies on a daily.
Absolutely. But also the other thing that we need to be conscious of is a lot of naturopathy, a lot of herbal medicines, whilst they're not synthetically derived in a laboratory, they are effectively hormones. Yeah. They are doing the same thing. They are estrogen or they are progesterone based. They are manipulating the hormones within a woman's cycle. The only difference between potentially naturopathy and a lot of the herbs that are given to women through Eastern medicine is the fact that a medical pharmaceutical grade medicine that's gone through the rigors of quality control trials and what we term randomized controlled trials, where you give a placebo drug, a sugar pill to someone and a real pill to someone, and then look at the outcomes in terms of safety and also efficacy, so how well the drugs work. That's gone through a regulatory process, right? Whereas the herbal medicine, most, if not all of them, have not gone through those double-blinded randomized controlled trials. Some of them will have, of course, absolutely, but generally speaking, not. So you do have this paradigm that just because you're taking something that's natural doesn't necessarily mean it's not going to manipulate your hormones and cause side effects as well. And, I'm really, one of the things that I love is when people post about, a medicine and it's got such and such, it's got this in it, hydrogen peroxide, and it's got this and so on and so forth. And when you look at the ingredients, they go, bang, look at this. And this is what causes such a bad thing. And it's got this in it. And that's what it's, the compounds of our body, we have hydrogen and we have oxygen in our body. There are things in our body that are normal, but mixed together, you can make a bomb out of them. Do you know what I mean?
Right.
And so this is the whole thing that you've got to look at things in terms of what the role of what they do and how they influence outcomes.
But that also goes that whole tunnel of social Google. Absolutely. And you just you go and you're like, and then you get to and you're like, what even am I reading now?
Correct.
Like you don't even know where it came from.
And the other thing is a lot of influencers out there talk about things as if there is a causation. And what I mean by that is let's say, for example, the oral contraceptive pill has seen a rise of cervical cancer.
Yeah.
Right? We have used the oral contraceptive pill and cervical cancer risks have increased. And that's not necessarily the pill causing an increased chance of cervical cancer, let's say. It's because the pill, whilst it helps with cancer of the ovary and cancer of the endometrium, people don't practice safe sex, then they're going to have an increase in having cervical cancer.
Yeah.
So it's a correlation, not a causation.
It's like when you go to like the States and you're listening to like their ads for drugs.
Absolutely.
And then there's like a disclaimer at the end, and this make you go blind.
Correct.
They still take it, right?
Well, but
do you know
also,
what I mean? Like it's still like if you read, there's certain things that of all that sort of stuff.
But we understand that every medication has a side effect, and this is what I say about the Mirena. If you're being advised to utilise the Mirena IUD as a device to help with period pain, then if it's something that you're amenable to, of course, it's all about informed decision making. A lot of medicine now has changed from historical to where we are now, where, again, patients in terms of all healthcare are empowered to make informed decisions. And if you feel that the decision is right for you, absolutely go ahead. And if it turns out to be the wrong thing, the worst thing you can do is you can put it in, and then at the worst case scenario is you just take it out because it's not the right thing for you.
Yeah. The other thing is that no one ever talks about the first period after having a baby.
Yes.
It's horrendous.
Yeah. That's not something I've experienced, but I'm happy for you to share.
Well, it's different to your first, right?
Yes.
So obviously it's a big bleed. And sometimes obviously if people have been on the pill, they're not actually used to their cycle. So then all of a sudden you feel like, oh my goodness, it's huge. And all the women will always say, oh my God, your first period, when that came, it's just this gush of blood. And there's that difference. I think that people don't really talk about it as much or knowing, is this really my period? Is it started? Is it not started? Even after a miscarriage, people go, well, is this my period or is this just a bleed?
Yeah. I mean, some women will get pregnant without having had a period.
Yeah, we know that if they're breastfeeding.
Correct. And I remember there was a couple who came and saw me and they came and saw me after about 5 years of trying to conceive. And, of course, at that point in time, we decided to do IVF.
Because there's a lot of people these days, Joe, still think that if they're breastfeeding,
they're going to be pregnant. That's right.
Yeah.
So they came after 5 years, and we did IVF, pregnant, and then they tried after a year or so, tried again naturally for 2 years because there wasn't anything that specifically was concerning with respect to their fertility. It was sort of an unexplained fertility issue. And then they came back and they did IVF after 2 years of trying and put an embryo in baby number 2. And I remember we were at the postnatal consult for their second baby, and I said, look, we need to talk about contraception. You guys, we've had to do IVF, but there's no real reason. The sperm's okay, the uterus is okay. There's no real reason why you can't get pregnant. And the husband said, he goes, Joe, it took us 5 years to get pregnant the first time and 2 years we had to do IVF the both times. Forget about it, mate. And I said, all right, okay. I said, it's up to you guys, right? They were back 6 weeks later pregnant with their third baby. So, you can definitely ovulate. So, and that's the thing about it, right? Your first period probably has occurred after you've ovulated.
Yeah.
And so you can actually ovulate, not know because you haven't had a period after you've breastfed or whilst you're breastfeeding and get pregnant.
So we have a patient that fell pregnant not long ago, and then 5 months later she had a spotting. She thought this was her period and then continued and then thought, oh my goodness, I'm pregnant. And she thought she was 13 weeks pregnant.
That's right. She was 20, wasn't she?
Yeah. She had an ultrasound and they're like, we're not doing a dating scan because your baby's 20 weeks.
That's right.
And she didn't realise because she'd spotted that all of a sudden, what was that? And that's what people don't understand. No, we get so confused. It's like, is this a period? Am I just spotting?
Absolutely.
And that's what people don't understand is that whole concept of that is this normal of what that is? And how would we know that anyway? By bloods? Like what would you do?
Well, I mean, as I said, you can have a period you can ovulate without necessarily having a period for that first time.
So even if there's a breakthrough of bleeding?
Absolutely. I remember actually a bit of a funny story. I was a registrar at the the Women's Hospital, and this patient was transferred from the Alfred Hospital, an Irish backpacker who'd been out celebrating the Melbourne Cup on a Tuesday, drinking a few champagnes, and she presented to the Alfred with severe abdominal pain. And the astute doctor there thought, okay, fair enough, we'll have a look, felt her tummy, went, that feels a bit solid there. They did an ultrasound scan and she was pregnant. So this Irish backpacker arrives to the Women's Hospital, and we popped on a CTG, which is an electrical trace of the baby's heart, and I did an ultrasound scan, and I guessed that the baby was probably around about 34, 35 weeks. She was about 30, 35 weeks.
She had no idea.
She had no idea. Obviously, been backpacking around Australia, having a lot of Guinness and a lot of champagne, and she was in labour.
How can you? I've had 2 babies.
Yes.
How do they not understand the kicks?
Well,
or do they just think it's really bad indigestion?
What
is that?
Maybe she was drinking a bit too much during the pregnancy. But
Jeez,
but she arrived at 35 weeks and in labour, and we ended up doing a caesarean section on a 35-year-old lady, a baby rather.
And was the mum like, what is...
Yeah, the mum was like having a call back to Ireland to go, hey, Mum, I've just had a baby.
She sounds a bit American there, but that's okay.
The American accent is derived from the Irish accent. Okay. To be sure.
Well, thanks, Joe. We'll talk more period talk throughout the season. Thanks for letting us know all about our cycles.
No dramas. Doula and The Doc, hosted by Vanessa Salerno at Perth.
Can we just put in the bloopers at the end?